is Alisa Geers, and I'm going to start our presentation focusing on a little bit of the rural Honduras nursing and some case studies. And then Debbie's going to follow up at the end of the presentation, or middle, talking about disaster care. So you get like a 2-for-1 this morning. So I live in Honduras. In the past 2 years, my husband Andrew and I have been there. And this is Andrew and I here. A little bit of my story is that when I was a teenager, I was on a mission trip to Botswana, Africa, in 13, and the Lord really spoke to me at the time and just kind of really pressed upon my part about how lucky I was to have been born in the United States. I saw many, many children playing in the slums, playing on trash bins, and I knew the Lord loved them, and me the same. But I couldn't wrap my heart around how they could have so little and I could have so much. And the Lord kind of told me, it doesn't matter. I love them the same. Your luck is no different than their luck, but you have a lot more that's required of you now. So ever since that time, I knew I wanted to go back into missions. I didn't know how exactly, but it ended up nursing, and nurse practitioning was the best fit for me. So we ended up 15 years later in Honduras. So why Honduras? Well, it's one of the poorest countries in the Western Hemisphere, and there's debate on the number, but I would say it's in the top 10. Some results say it's 2. Haiti for sure is number 1. Where Honduras lies is just up to question exactly. So over half the population of Honduras lives below the poverty line. And in our area, the average monthly income is like about $170. So if you can imagine living off of that for a whole family, it'd be a little bit tough. So we're in the northern coast of Honduras, kind of right here. And the next nearest hospital is an hour and a half away. And that's if you have great transportation, which none of our patients really do. They'd have to take a chicken bus, just like a public bus, or get someone to take them in the back of a pickup truck. So we are in a very rural area. And this is an overview, just a picture of the hospital there. Our hospital sees about 15,000 outpatient patients per year. They do 1,000 surgeries. We do pediatrics, OB, prenatal care, optometry, x-ray, laboratory, inpatient care, all kinds of different fun things. So just a little bit about what we do. And some of you probably had an in-depth introduction of the hospital, so I'm not going to go super in-depth with that right now. So I just wanted to pose a couple questions for you. I have seen many nurses that have been abroad or thinking about going abroad, and just wanted to think about your scope of practice as you go abroad. It wasn't a question that I had thought about before I went. Do you know what your scope of practice will be? Do you know what you're going to be doing in the location that you're at? Sometimes you don't know exactly, which is okay. I don't think I knew exactly what we'd be doing. But I feel like in the U.S., the lines are very clearly drawn. You have laws and rules and regulations of exactly what you should be doing and what you shouldn't. You know what that is. But when you're traveling in a different country, you might not know what their laws are. It might be different than what it is here. And sometimes the lines get really, really blurry. And we've seen some great things from this and some not so great things from this, just where there's a little bit confusion. So you will probably be put out of your comfort zone when you're traveling. You're going to be in a different climate and a different culture. But I would never encourage anybody to be out of their comfort zone in regards of their clinical experience. So as you are thinking about missions and what you're going to be doing, in the back of your mind, in the midst of all the other logistical things that you have to go through, I would always just encourage you to be practicing within your scope. If there is a fracture and someone says, hey, can you go set that bone? And you've never set a bone in your life, this is not the time to start. A good answer maybe would be, I've never done that, but I'd love to learn. Can you teach me how? And maybe the next time I can help you. These are things that have happened to my husband and I. Sometimes it's just because the people that we're working with don't know how comfortable we are or our scope. And sometimes they're just really busy and they don't have any other option, and so they're trying to get a little bit of help. But it's just best for the patient if you stay within your scope. So we kind of talked about, should you be going outside of your scope? Is it broader or narrower? Well, you asked for that. So one example of this, this is a patient that came in for a transfer. And sorry for the graphic pictures, I should have given you a warning, but they said, oh, he has a tibulofibular fracture. And what they didn't tell us is he has a huge crushing injury to the foot that they tried to fix with these pins. They didn't stabilize his fracture at all. As you can see, his leg is bent at an unnatural angle. They did suture up some of his lacerations here, but they made a mess of his foot. So this is an example of a hospital that doesn't normally do orthopedics, that tried to do orthopedics, and ultimately this patient had to get an amputation. They also sutured up his hand, but in the midst of just focusing on his foot, missed that his hand had several tendon lacerations as well, and he could not close his hand. So just an example, stay within your scope, try and do what you can, but there's always probably going to be someone who is more of an expert than you are that the patient could probably get to. You might not know what those resources are, but you can probably try and find out. So relationships with other medical providers. I'm just gonna look at my time here. Are you involved with any clinics or medical providers on the ground of where the country is that you're going to? So are you going to a standalone clinic or brigade? We call them brigadas. And is there anybody we need doing follow-up with you or with those patients after you leave? Is the church that you're going with, do they have connections on the ground? Are you connected to the local hospitals that are there? So just some thoughts to go through in your mind as you're picking places to go or organizations to go with. We found that people who come to our hospital that come regularly, routinely, once a year, have a huge impact on our hospital, and it's so much more helpful than first-time visitors. When they come back year after year after year, they know our system. They can sometimes see the same patients that they've seen before. It makes an amazing impact. So if your program goes to a different location every year, that could be great and fine. They might have different connections there, but we have just seen how a deep investment really impacts our hospital. All right, so now for the fun part, some case studies. And we based it off of Matthew 11:5. The blind can see, the lame can walk. Those who suffer from dreaded skin diseases are made clean. The deaf hear, the dead are brought back to life. The good news is preached to the poor. So we're going to talk about the blind seeing at one point. We had an 18-year-old working with a weed whacker come in who had a ruptured globe to his left eye. He was weed whacking without any eye protection, and a rock came up and hit him in the eye. So he was probably in the zone 2 to 3 here. And we don't have any ophthalmologists on staff. We have a general surgeon. When this person came into the ER and I was on call, I thought, no, not me. Why? Just those moments where you feel totally inadequate. So we realized that this was a devastating injury to a young man, and quickly called up our surgeon and said, "Is there anything you think you can do?" And within 30 minutes, he pulled him back into the OR and was trying to close the laceration in his eye and close his globe. Our goal was to maybe save his eye. We wanted to hope that, it didn't have to be removed. And as you can see, these types of surgeries, I don't know if you've ever seen them before, it's done microscopically. The sutures and the material is like doll toys, and the suture, one of the other doctors described it as spider thread. You can barely even see it. It's teeny weeny. So that our general surgeon was even attempting this was kind of miraculous. And 2 days later, when we took off his eye patch, he was seeing light and dark. And within a week, he was seeing various shapes. And it was such a miracle that he was not only didn't lose his eye, but he was seeing things again. So the blind see. The lame walk. There's another example this past year or two. We call this case cow versus moto. And a 19-year-old was driving his motorcycle in the middle of the night. He didn't have any lights on his motorcycle. And there was a black cow in the middle of the road, which is not uncommon for our rural areas. But he ended up going face first through the cow. And he came to our hospital in a comatose state. We didn't think that he would ever recover, and he had actually broken his face. They call it, he had a Lefort fracture, 3 on one side and 2 on the other, which is basically so fractured so much that his face is detached. Sorry, the bottom half of his face is detached from his head. So it can move, and you can really change what you look like. So the family had to bring in photos of what he looked like before, and we had a maxillofacial surgeon at the time, which was incredible, and he was able to repair some of the injuries to his face with using the photos from before, because his eyes had sunken in, his nose had moved locations, and he woke up from his coma. In addition to his facial injuries, which is always, that's just the shocking part that I had thought. Let me read some of his other, because I don't think I'll get it all right. Let's see. Several rib fractures, mid-shaft humerus fractures, vertebrae fractures, pneumothorax, and 3 days in a coma. And this is him 1 month afterwards. He woke up and began to try and speak and grunting and pointing. And after a month, he was able to leave and go back home. So the lame were walking. And the last one we're going to do, skin diseases are healed. This is the barba amarilla, which is the most venomous snake that we have in our area. If you don't get antivenom for this snake in a few hours after being bitten, it is lethal. It's really, really dangerous. So the next picture is a little bit graphic, but we're nurses, right? So this, Sarah came to our hospital. She was a teenager as well. She was about 16, 4 days after she was bitten by the barba amarilla. She had gotten the antivenom, but developed complications in another hospital of compartment syndrome in her arm. She was bitten in the forearm, developed compartment syndrome, and they did the release at the other hospital there. But unfortunately, they left her arm as so for 4 days and didn't do anything to close the wound, didn't do any other treatment. And so her family got upset and decided this was not working for us and came to our hospital to try and get some more treatment. We had to put her under anesthesia to take off her bandages. It was so severe, and the wound was infected. They hadn't changed the bandages for many days. And you can see it's like an anatomy lesson just her arm there. And our surgeon, because her skin was so swollen, had to use special rubber band sutures in order to stretch the skin back. He has some great trauma experience from some Army experience that he had there. This is one thing that they use on the field. So he did a staple rubber band type suture, and with elevation and time and a lot of antibiotics, her skin was able to actually reduce the swelling and get small enough where they could close it in the OR. And her final results actually looked really good. Yeah. Skin diseases are healed. And there are other stories about the deaf hearing and the dead being brought back to life, but we don't have time for those right now. But I did want to highlight the good news is preached to the poor at our hospital here. Every morning, and every patient is prayed over and exposed to the gospel at our hospital. And that is one of our favorite things. Even though these crazy cases walk through the door, our goal is to always point people back to Christ in Honduras. So I have 1 minute left, and I just wanted to encourage you guys and ladies and nurses that you can do it. You can be a part of this. This could be your clinical case in the next year in your trip that you go to. And I hope that this conference encourages you to make that next step.
Question while I switch over.
Any questions while we are switching at the moment? Yes. Yeah, I think that the scope of practice that you've been practicing in the military would serve you well in another country as well. I think it's just wise to always be, that was my 20 minutes. Wise to be always having that in the back of your mind. If you have a lot of, in our hospital, we train up lay people to be doing nurse tech jobs. They don't have a specific licensure or certification that maybe in the States you'd have like as a medical assistant, but they're doing the job as a medical assistant. And that's okay in Honduras. And that's not going to be getting anybody in trouble or a hospital in trouble. What happens is, and we've had it at our hospital too, is a surgeon will come in and maybe take a case that was a little bit big for them, or they didn't realize, or the tools are a little bit different than what they're used to. They don't have the same support staff in the OR, and there might be a lot of blood loss, unexpected, and so some of our surgeons will have to hop in and be sweating together and do some things, and it makes everybody really nervous. And so, and the outcome for the patient might not have been the best if they had kind of evaluated it a little bit more sooner. So even our hospital is not perfect in that. And one last question.
Just a comment. There's some great resources. It's ICRC Volume 1 and 2 for war surgery. It's available online. It's downloaded in PDF. There's an organization called globalhealth.org that has multiple textbooks available online that's available to missionaries.
Thank you.
Great. Thanks. So we're going to move on with the next step, which we're going to talk a little bit about disaster nursing. I can already see I've got some sort of better experts than me that are here this morning. So after we finish, we'll have a time where we can talk and talk a little bit more about disaster nursing. And they asked me to talk about disaster nursing, but obviously when you respond to a disaster, you need a multidisciplinary team. So nurses are great, and I'll talk about why nurses are great because I'm pro-nurse, but we obviously need all members of the healthcare team, right? So everybody's really important. And I think when we talk about what's in our hand, disaster nursing really is a little bit the epitome of this because it's more about what's in your head than what you can always take with you. You know, I'm a planner. I like to plan. I like to be prepared. But when you're told with an hour's notice, pack up your backpack, we're evacuating from this place, you don't have a lot of time. So you have to think about what's going on. I do think that nursing in general, most people know it's not just a job, it's an adventure. So disaster nursing sort of just takes that to another level, right? We always have to remember, though, really, why do we do it? Like, why are we doing it? There's tons of organizations out there now working in disaster, right? Disaster is actually kind of a big business these days. It's a big area, and you begin to look around and you realize not everyone's doing it because they really want to share the love of Christ. And that's okay. They're doing good humanitarian work and maybe saving lives, but why are we doing it? You know, we're doing it because we want to be Jesus to those people. We want to offer the highest level of expertise and care that we can, which is different than it is here in a developed country in our ERs or our ICUs or our trauma centers, right? It's different. We might be offering the best possible care, not really the best standard of care we would think elsewhere, but we really want to minister to the hurting because we have hope through Jesus and we really want to share that hope with others. And so I like this quote. For Jesus, there's no countries to be conquered, no ideologies to be imposed, and no people to be dominated. There are only children, women, and men to be loved. And I particularly like that he put children first. So, because kids are always my favorite. So, what is a disaster? Some of you go to work here in the States and you think this is a disaster because it is. You may be working in an area where you deal with mass casualties or just an overload of patients or a lot of situations that you haven't encountered before, so it's a disaster. But technically, the real definition is an event that overwhelms the local capacity to respond and alters its ability to provide safety and health for its inhabitants, and ultimately causes human suffering. And I want to thank Samaritan's Purse because a lot of these slides come from SP. A few are personal ones I've taken, but many are borrowed. And again, disaster response is really a team effort. When I put this together, knowing I had 20 minutes, I didn't actually put in gory slides, sorry. But I'm glad Alisa did because you got some of those gory slides. I decided I had to sort of do an overview of disaster nursing and to talk a little bit about if you're not already involved in it, but you want to be, what are some ways you can prepare and what are some things you can do? So disaster response is really a team effort, and I think nurses are part of the key to being a part of that team because we're highly skilled, we're used to chaos, right? We're used to trying to create structure out of chaos, usually pretty adaptable, culturally sensitive, resilient, and we educate. And as you know, anywhere you work, nurses usually get the job of subbing in for any other group that's not there at the time, right? So like as Alisa says, like your scope of practice might be a little bit extended in a particular area depending on where you're working, who you're working with, and your level of comfort. So you might kind of be the doc for a few minutes, you might be the chaplain, you might be the cleaner, you might have to clean up and change things, you might be the counselor. I stuck this in after I taped my other session. I thought it was a little harsh, but the people there thought it was fine. I do want to mention as we talk about disaster response, like I'm old. I've been a nurse for 30 some years, long time. When I first started, if we did disaster relief in the first few years of my practice, we just went. We just went and everybody said, it's a disaster. Whatever you can do will be better than whatever they have now. Disaster response now is way above that. It's It's so much better. It's so much more organized. There's huge bodies of knowledge. We now know what works, what doesn't work. And one of the things we do know, and I always want to caution, is don't go alone. I'll talk about some great organizations. There are more organizations than that for sure than I could talk about in a 20-minute session. But one of the things we want to make sure is that people don't think anymore it's a good idea to throw on your backpack, hop on a plane, show up in a country and say, here I am, I came to help, and become a part of the liability and a part of the problem. So what we do think you can do is start honing your skills and talents with training. So there's lots of different things you can do. I see some DART people sitting here, so they're probably going to get flooded at their booth after this. But they offer training, right? They offer either on-site training or modules you can take. MedAir is another Christian organization that does a good job of training with their rehab orientation course and response orientation course. Christian Health Services Corps has tropical medicine courses, Sphere standard courses, which is all about disaster response, tropical medicine. Someone mentioned the military. So the military, as you know, is one of the first that's been involved with disaster response. So military training is great, and many times you can join organizations that train with the military or alongside the military for response. There's online modules, there's lots of state and federal training courses. So I know I am in Oklahoma some, I have a house in Oklahoma, I technically live in Oklahoma. I belong to the Medical Response Corps in Oklahoma. I'm sure Texas has a huge one, and probably multiple, but every state usually has a response. So no matter where you are and where you're going, whether it's a Greek refugee response, you see the little Medicine Sans Frontiers sign down at the end of that. This is an Ebola response slide from a Samaritan's Purse, or whether you're helping deliver a baby in a cholera treatment center, it helps to have some preparation and to be ready to go. There are international standards for disaster response now, and if you've gone to any of the Christian Health Services Corps offerings, you'll realize that the Sphere Handbook is one of the internationally known standards, so that's out there and available. The Red Cross and Red Crescent, Medicine Sans Frontiers, which is Doctors Without Borders, has a lot of evidence-based practice guidelines and protocols that they put out. There's UNHCR, and depending on what kind of disaster you're responding to, there's lots and lots of others. So we think of disaster, and my mind jumps automatically to natural disasters, right? So there's earthquakes, hurricanes, floods, things where you're going to deal with traumas and crush injuries and pulling people out of rubble and trying to figure out how to fix them. But there's also others, like, for example, the Ebola response here that's happening now again, infectious disease responses, and then there's the things that man does to man, right? Civil unrest, civil war. Things like what's happening in Syria and all those sorts of things. So there are a lot of organizations working in disaster response now. I've listed a few, just a few that I'm familiar with, but there are a zillion more out there. Again, Samaritan's Purse, MedAir, AmeriCares, Baptist Disaster Relief. Lots of the denominations have organizations that are getting better and better in training, MSF, and there's so many others. So as I mentioned before, I bring this up because it's pretty hard to do anything of real impact on your own. So if you join a group that's used to it, that has the resources, that has the ability to help you transfer a patient that you can't do anything for, that has the knowledge of what's going on and some of the cultural knowledge of what's happening, you're much better off. So in addition to training, I say get out there, just get some international experience, right? Go and travel. If you've never been out of the country, this is not the first time to hop on a plane and go end up in the Philippines after hurricanes, floods, cyclones, or in Haiti after Hurricane Matthew, or after a volcano erupts. It's really not a good first time to hit the ground and say, oh gosh, wait a minute, I don't even know how to get there. How do I do all this? So get some international experience. Get out there on the field, do what you can do, you and start getting some good experience of how to travel, how to live without all the luxuries that you have back at home. You know, as nurses, it's a bit of a challenge sometimes, right? Because if you've never been on the mission field, you might forget that you can create an Ambu bag out of an old IV bottle and a tongue blade and some tape, right? Or you might forget how many things you can do with duct tape, a Sharpie marker, and a pair of hemostats. I mean, challenge yourself, right? So you've got to get out and do some of it. I would talk about the fact that disaster, there's the initial response, and that's what everybody wants to go to and what everyone's all excited about. Okay, I want to have that backpack ready so when they call me, I can respond within 24 hours, 72 hours, get out there, hit the ground running, and do some good. But there are responses and there are stages to responses. So the initial response is always the aid. It's always the initial life-saving responses. It's an assessment of the situation, trying to look at safety. Some of these things, you know, by the nature of the fact that it's a disaster, these things are overwhelming the local capacity, and often the local capacity wasn't great to begin with. So when you take away more infrastructure because bridges are down and roads are closed and the people now haven't had any clean water or food for a couple days and they're mad at their government and they start rioting, so you can't travel on the few roads that are open. I say only this because last week we came out of Haiti on helicopters. My first helicopter ride that wasn't a medical helicopter ride, just because of civil unrest. So when you go to these countries, you have to always be thinking, what's happening there, not just in the disaster realm? What's happening politically? What's happening from a civil standpoint? And so you normally have a team that goes in or is already on the ground that will assess the situation and start looking at the safety factors to bring in more people. And then there's a decision to engage in the response. So as you notice, there are disasters all the time now, right? And not every organization and not every team can respond to every disaster. So there has to be some assessment of which ones can we commit resources to, which ones are we the best at, which ones can we go into, and are we already tied up and committed to other disasters? But there's many organizations these days. So you go in, and first is rescue, of course. We're going to go in and we're going to stabilize and rescue as many as we can. Then we have to get innovative about how we respond to other things. So in the States, we pride ourselves on best practices, right? Do we know the evidence-based practice? Do we do the evidence-based practice? Do we create systems and processes so that those can happen? But on the field, we switch our mind a little bit to what's the best possible practice. How do we make it work? In Haiti, we call this dégagé. Anywhere you go, you can call it innovation. But how do we make this work to do the best that we can for our patients and the groups around us with very limited resources and having to innovate constantly? So we're trying to create effective structures in a very chaotic environment and often a very austere environment. So if you're the type that only likes glamping, or you're just have a particular affinity to hot water, maybe disaster response isn't for you. Because you may have to put up with for a while crowded conditions, sleeping on cots or sleeping bags if you're lucky, doing things that you wouldn't usually do just to be able to be in that environment. And then after the initial response, which is critical and which is crucial, then there's generally an ongoing response, right? So there will be a first wave and then there will be more waves going in. So the first wave, again, is usually setting up the structures, setting up the initial processes, stabilizing as many people as you can. And after that, you'll have usually ongoing responses, and sometimes it's still evolving, right? So you go in and you see from an earthquake in Haiti, a bunch of crush injuries. And you stabilize and you put on all kinds of fixator devices, and lots of people come in and then lots of people leave. And so the people that are left, I remember this in our cholera treatment center, which was 11 months after the earthquake, people coming in with external fixator devices still on. They had cholera usually, but They also had external fixator devices and casts on from 11 months before. So people were there and they got an initial response and then they didn't. But that's also a good example of the fact that structures were crushed. Many different things happen. The CDC and the WHO actually predicted there's going to be a waterborne illness here. And sure enough, there was a whole cholera epidemic following that. And that's not unusual, right? So you've got the first wave, and then you've got the evolving responses that are happening, which often are infectious disease responses. And again, you have to pay attention to civil unrest and infrastructure collapse and many other larger issues. Now, the UN, the United Nations, usually plays a big role in this. And at some point in time, they're going to enter the scene, usually early, and start looking at a cluster response and start trying to help coordinate. So sometimes you're the person down at the lower level in the scrubs, mucking around in the yucky stuff. And sometimes you got to clean up a little bit, take a shower, and go to a UN cluster meeting. So there's a whole range of things that happen in disaster response. And because of that, I think we're each uniquely qualified because you never know what little things that God has created in your life, little experiences he's put in there that you have no idea why that ever happened, that are going to be used in these situations where, you look around. As we were evacuating last week from Haiti, I have a friend that's deaf, a Haitian friend that's deaf at the airport, and he was trying to help these groups get out, and he came up, and we're like, oh, hi, I don't sign. And so I turned to my group of students, I go, anybody sign? And they're like, yeah, sure. So a girl at the back is signing with this guy, trying to tell us what we need. And she was like, this is amazing. How did I ever know that I was going to need American Sign Language evacuating from Haiti? So you never know, but God gives you these things really just for such a time as this. So it's kind of like being ready for what you don't know you need to be ready for, right? So this is where we depend highly on God, on Jesus and the experiences he's given us in the past. This is a good friend of mine in the Iraqi field hospital that Samaritan's Purse had in Mosul. We have a lot of skills. We have a lot of expertise. We also can bring compassionate, loving care, right? Any of you that have been overseas realize that this is generally what draws not just the patients to Christ, but the other people that you're working with, the local staff and the people that are helping you as translators and the washers and the cleaners. When they see that you've come, given up your time, your effort, your ability to be clean and comfortable, and you've come and you've been compassionate with their people, that you've been kind and loving to people you've never met before, because in their culture, they're kind and loving generally to the people in their circle. But what if you're kind and loving to people you've never met before? What a witness. This is where you tend to get the most questions later on when you have those few minutes to sit around at night and talk to the local people like, well, how can you do this? Why are you here? I want to talk a little bit about, if you're going to do this a lot, some things you need to keep going, surviving and thriving, because you often do see the worst things that man can do to man. I think, in my mind, there's a totally different level if I'm responding to a natural disaster that was beyond anyone's control than if I'm responding to something where man was cruel to other men, where, ISIS has purposely targeted women and children in places like this, in places where children's hospitals and hospitals are purposely targeted, what man can do to man. And you start to see the savageness, and you see people at the worst moments, and you work your hardest, and you're totally exhausted. And how do you survive with your faith intact? How do you show the love of Jesus when you're just totally exhausted and you feel like you have no more to give? So there's a few strategies for the trenches, and I'm going to go through this quickly because we're almost done. Do a couple things for yourself every day. For me, this is hold a baby if I can find a baby. If I can't find a baby, shave your legs. I'll never forget in Haiti, Franklin came. Franklin Graham came and he had Greta Van Susteren with him and some other people. And I don't know, it was just a Sunday afternoon. It was our few hours off. And we were in the bathroom shaving our legs, and who walks in? It's like Greta. And we're like, oh, hi. And then this was our break, like shaving your legs. And so we had to offer her a clean scrub top to dry her hands on. And we were like, oh my, we met these people in the bathroom. Sing and dance, watch a sunset, find something beautiful, and try to figure out how to keep going. I can't do a presentation and not put in cute kid slides. It's just not possible. So here's some cute little kid slides for you. Obviously, insulate yourself with the Word of God, with fellowship when fellowship is available. You have to mourn and grieve, and then you have to realize, you have to give it to God like everything else and realize Jesus loves them even more than I do. So this is traumatic, and I'm traumatized, but Jesus loves them even more than I do. And realize that you have to give yourself some grace, and you can keep going, generally, if you help one another. So Micah 6:8, I like to paraphrase this, but this is one of my favorites. It's basically, don't be daunted by the enormity of the world's grief. There's so much grief out there. There's so much you could be upset by. But what are we called to do? We're called to do justly. We're called to love mercy and to walk humbly with our God. And often we're called to do those now. And we're only a part of the picture, and we have to realize that. Like, we aren't going to complete that work. That work's going to happen through the Holy Spirit, and Jesus is going to make that happen. But also, we're not called to abandon it, so we have a part to play in that. So here's my version of a happy hour. On the Caribbean sunset is great for that. So anywhere you can get it, you should take it.